we have obviously a lots of patients need a lots of help. And when you start with easier cases, obviously, but then you progress and you can do more complex cases. And I'm hoping that Dr. Gasco and I, myself and Dr. Shell and everybody here can help future candidates, future surgeons, to not make the same learning curve, but add to our learning curve. And this is what my talk is about, doing complex cases. Definitely, these are not things you will start with. And now, Kambin and Trans-Kambin, the Kambin triangle and Trans-Kambin approaches are now a fashion, are becoming a fashionable things. We talked about what you can achieve, and I just want to emphasize, you can do this surgery with a handful of tests, handful of tools, and if you can master this handful of tools, you can truly do magic with your skills. And we talked about that. Thank you, Varun, for visualizing that. People ask, can you do discectomy? Can you prepare end plates? Yes, if you get experience in that, you can do all of that. But more importantly, I think, you can do place, as Dr. Gasco was alluding to. You can choose where you put the cage. You can choose to put the cage in the front, in the back, in the right, left for sagittal and coronal deformity. You can influence the location of the cage, and that can help you. Now, there are techniques that I'm not going to go in depth about how you can do that. That's another talk, so stay tuned. But practically, one of the things you can do, you can control your whole environment and do given cases that Dr. Gasco was showing to you. And obviously, those grade 2 L5S1 should not be the first 50 cases, but believe it or not, you can get there within no time. Now, I want to talk about a few things that there is this learning curve we talked about. Is for each, we have made a science of it. For each of these procedures, that new procedures that you do at the next level, grade 2 spondylolisthesis, each of them has its own learning curve. And this learning curve, it's about 10 to 15 cases. It's not many, but we should expect that we cannot start this and expect to do a 4-level fusion as our 8th case. Okay, that is important. Now, one of these advanced cases that we have published a paper about is the Trans-Facet OLLIF. And again, when I started doing OLLIF, in my first 100 cases, half of the L5S1, I have to open it, do it old-fashioned way. So we actually created a setup in the OR that we go from OLLIF to open in 5 minutes. Now we go in 3 minutes. In 3 minutes, we can go from OLLIF to do an open surgery, but the setup is important. There are lots of information that I will be able to share with you later on about how to set up the surgery from the start, that if you need to go OLLIF, from OLLIF to open, it takes you literally 3 minutes. So the threshold to do the safe thing, to go to open, is lower in the Trans-Facet OLLIF. But then we came up, at the beginning, in the first 100 cases, I had to convert half of those 5S1 to open, but then I noticed I'm getting better, but I didn't accept I'm just getting better. I analyzed the pictures, and then we came up with a method that we published a paper in 2017. Practically, that method is a prone lateral for 5S1. Years before the prone lateral was a big word, we have been doing that. There's a paper that we published, and we will share it on our Kambin Society meeting with you. But then still, I had to do 2 to 4 cases a year, still go open. Since 2018, when we started doing Trans-Facet OLLIF, and 2019 we published our paper, I did not need to open any of these cases anymore. Practically, in the Trans-Facet OLLIF, you are still doing an OLLIF, but the hypertrophied part of the facet, you drill it down to create your approach to the Kambin triangle. And practically, you have to make sure that your trajectory is fixed in the method you want. You have to be a master of this instrument. And then you drill while you're stimulating under 12 milliamp, 10 to 12 milliamp, the whole instrumentation. And you drill, and you're in the axilla of the L5 nerve root and the S1. and you go in and you're stimulating at 10 milliamps. So practically you would know if you are there. And here is a video of it. Let me see if I can run this for you. Practically what you do is use a stepwise drill. You fix the trajectory. Once you fix the trajectory on the hypertrophied part of the facet, you use a series of drills to drill through the lateral part of the hypertrophied facet to literally open up the Kambin triangle. Now, this is still not a transforaminal TLIF. You're still truly in the Kambin triangle. Again, we have published a paper. We have a lot of videos in the sense of that we should be efficient. I'm just going to go to the next slide, where you see actual X-ray of this procedure. So I'm going to explain it to you. You practically, I still use my neuromonitoring tool. I put it on an area that is practically give me an exact, no, the first thing is I put a Jamshidi, get the bone marrow, and here you see the trajectory that would take me to Kambin triangle and to the disc. Then we have a better method now, but then here we put a small drill, a two-step drill that first the dilator, then the tube, then a two-step drill that we drill little by little under 10 milliamp of stimulation until we get through the bony structure. As you see here, the tube and the drill are advancing at the same time, and you see now the K-wire is entered to the Kambin triangle. Now here you see you are pretty medial, and that enables us to put the cage quiet in the central position. Now, this is practically a backup technique if you cannot get to L5S1. The safety profile of it is much better than if you cannot get the right angle and have to push the nerve to the side, because as you see, you're truly in the axilla of the nerve between L5 and S1, and nature, God, evolution gave you really a pass, free pass here. So I will talk in one of our next meeting more extensively only about this, but we have a few other things I want to show you. So I will proceed now to the next slide. Now, this is the same slide, so I'm not going to go through this. So let me go to the next slide. Now, one of the other things that I want to talk to you about is that so-called expandable cage. It makes sense, at least originally, to have a lower profile cage that when you are in place, you can expand and create more decompression. Now, all the problem with these things are that they have lots of intricate pieces. Number one, you cannot pack inside with the biologic. Number two, those intricate pieces, by the time you really want to provide the pressure you need, at least in my hand, 1/3 to half of the time, they fail you. So even though I love the idea of expanding the place, these cages never worked for me. But what we did work for me is using the static cage in a lower profile, go through the Kambin triangle, because superior, inferior, you're confined by bone. But anteriorly, which is where the nerve root is, the nerve root can float more. So if you put the cage in the lower profile, literally 90 degree, and then once you're there, you turn it 90 degree, then you go from a static cage to an expandable cage with no additional complication or no additional pieces, internal pieces. Some of those pins in this expandable cage are 0.5 millimeter, and you have to provide lots of pressure with a pin that's so small, so they can fail. Now, let me show you actually a picture of that. So practically, you go in the lower profile. Once you're in place, there's a specific technique. Then you literally, you turn it 90 degree. But then once you have done that, you advance it few more millimeters so that it's not resting on the same place, as you see here. And there are some other videos that can show you actually that as well, how this works. That is another advanced technique that can be utilized. One of the other advanced technique that I want to show you, and that I'm hoping, that with the more experience you can get into that, is cases like this where is that using the K-wire, like what our interventional colleagues do, and put a small bend on the K-wire and pass over the osteophyte to enter. You see here, we go here, we put a small little bend on the K-wire and use the natural trajectory of the K-wire to get in the very difficult spaces. I want to show you the on the X-ray. Here you see that if you are coming in with the neuromonitoring probe and we put a small little bend, then we use the bend and turn the bend of the K-wire in the direction that's more suitable. Once we are there, then we can put it into the disc base, and the dilator does the rest of the job for you. Our interventionist colleague has been using it for a very long time and with some good experience, but you have to have good dexterity with this set of tools before you use this technique. Now, I'm going to move on to one of the other things that I want to talk to you about. And that is, let me see, in the collapsed disc, I just want to quickly show you, even in the most collapsed disc, once you get the dilator in, you can actually use the dilator itself here to open up the Kambin triangle. So the Kambin triangle, it's not a fixed base. You can enlarge in it. And our advantage is that the nerve root is very close to the lower part of the pedicle. Once you're increasing the size of the Kambin triangle, you're pushing, as Dr. Agarwal pointed to, you're pushing the nerve away and enlarging the triangle. So one of the last advanced kind of things I want to show you about, and by the way, and then once you're a master of this, you can do really many cases that you wouldn't think you can do. Here you see that a patient has a huge osteophyte, and once you are a master of this instrument, you can actually put your instrumentation on the osteophyte, enter it, and actually use that to lift up, to compare that how this is now before and after. Not only you're increasing the interpedicular lateral recess and foraminal space, but as well by eccentrically putting the cage in, you're correcting the deformity. Yesterday, in my surgery center, we did a scoliosis surgery on a patient with BMI of 48. We did that under 1 hour. Patient went home in less than 2 hours after surgery. And this was a patient that 2 other surgeons said, because of the BMI, they couldn't help this patient. So not only we did that, we did it in our surgery center on a BMI of 48 and send the patient home less than 2 hours after surgery. And that is the power that everybody in this group is now alluding to. Now, one of the last things I want to show you today is the so-called, we are going to talk about posterolateral fusion. I'm not going to talk about the OLLIF cage retrieval. That's a matter for another conversation. But posterolateral fusion. Now, obviously, in the Trans-Kambin approach, we are relying on interbody fusion, and many of you have alluded that you can do discectomy, you can prepare the end plate, and the fusion happens a lot faster if you don't destroy the vascularization of the spine by stripping the muscle from posterior element. But what about posterolateral fusion? Now, obviously, we start the surgery by putting a Jamshidi and a K-wire in the disc space. And then our device, and I'm encouraging you, connect to us. We are happy to share this information with you, is an eccentrically positioned dilator that goes, and the tip of it literally centers on the facet. We grind the surface of the facet and then put biologic here, and then put it in that pores that we just opened. And it takes about 30 seconds per facet to have additional posterolateral fusion. So, and here you see the work of this, and I want to show you one video. And there are additional instruments if you want to be more aggressive.